Hello and welcome everyone to today's seminar. My name is JJ Rotman, a representative of Ortholine, a medical technology company. Today we've partnered with Dr. Robert Burke, an orthopedic surgeon at the Texas Orthopedic Hospital, to hold a knee pain seminar to discuss knee pain options and available treatment options. Since the seminar is hosted on Facebook Live, attendees are automatically muted. So if anyone has a question during the presentation, please type them into the comment section below or located off to the right. I'll be notified when this happens, and we'll have time at the end of the presentation to address everything that comes through. So Dr. Burke, without further delay, the controls are all yours and we can get started as soon as you're ready.
All righty, thank you. So basically what we'd like to talk about today is the definition of what is osteoarthritis, what are the main symptoms of arthritis, and the various treatments for arthritis, be it non-surgical or surgical. Osteoarthritis is a very simple condition, which is basically a wear of the articular cartilage in a joint, whether it's the knee, hip, shoulder, and it is due to the loss of articular cartilage that occurs either with trauma or over time. The symptoms of arthritis can vary, but the most common symptoms are pain, stiffness, swelling, and decreased functional ability. There are various treatments for osteoarthritis, the non-surgical ones consisting of oral anti-inflammatories. Also, bracing can be potentially effective, use of a knee brace, physiotherapy, and then there are injectable treatments such as corticosteroids or viscoelastic medications, which are very numerous ones, which basically act as a lubricant for the joint. The surgical options can consist of arthroscopy, which is basically doing a debridement of loose or unstable flaps of articular cartilage. Sometimes osteotomies can be performed, which is a realignment of the joint in a patient that has isolated arthritis in one part of their knee versus complete loss of cartilage throughout the entire knee, and then either partial or complete total knee arthroplasty. What the Neoline surgery does is to make the process of total knee arthroplasty much more producible and more predictive as far as the outcomes. There is no question that the outcomes of knee arthroplasty depend greatly upon the overall alignment of the knee at the completion of the surgical procedure. With the use of the Neoline system, it allows real-time computer guidance in order to direct the procedure utilizing real-time imaging to precisely create the normal anatomic axis of the lower extremity as a result of the surgery itself. One of the biggest problems that patients have with osteoarthritis is loss of functional ability, such as being able to participate in activities such as golf or tennis, or being able to exercise, or being able to go out and go for long walks with your family or children. They also have difficulty going up and down stairs because of weakness and or pain. And this is something that affects millions and millions of people throughout the world. It is becoming more common as our patient population ages, and it is one of the more debilitating issues that patients will have as they progress in their life. Osteoarthritis is a very progressive disease. It normally starts out with minor cartilage loss, potentially due to a traumatic injury when somebody is younger, or it can occur also in middle age. And then as time goes on, the arthritis can progress to more focal full thickness loss of articular cartilage, which can result in more stiffness, swelling, deformities such as bowing of the extremity, either knock-kneed or bow-legged, and then it can finally develop into end-stage arthritis, which is basically one having debilitating pain on a fairly daily basis, along with pain at rest and inability to do simple tasks such as going up and down stairs or walking for a long period of time. Stiffness is a very common problem, especially the inability to fully extend the knee. Swelling can often occur due to the progression of arthritis, due to the sloughing of the articular cartilage, producing a mechanical irritation in the joint. Often people will hear or feel popping or cracking, which is the grinding of the arthritic bone as it moves against each other. And this is often something that can occur in multiple extremities, whether it be the knee or the hip. Also can occur in the shoulder as well. So the biggest consideration that patients have regarding the treatment for their osteoarthritis is to what extent does this affect their quality of life. In patients that have occasional pain on an infrequent basis, often non-operative interventions such as anti-inflammatories, physiotherapy, or just a routine low-impact home exercise program can be quite effective. Patients that have progressive disease where it's becoming more often occurring, often may require injection therapy such as corticosteroids or viscoelastic treatment. And then finally, the group of patients that are having pain basically on a daily basis that is greatly interfering with their quality of life and have had no significant improvement despite appropriate non-operative treatment would be considered for joint arthroplasty. We know that weight loss can be effective. There is definitely a correlation between obesity and the severity of the osteoarthritic symptoms. The difficulty with patients that are obese that have osteoarthritis is the ability for them to exercise to the point that they can optimally lose weight. It is extremely difficult with a painful arthritic joint for a patient to be able to exercise to a point that with a combination of exercise and diet, that they can actually have significant weight loss reduction. There's no question that rehabilitation, working on strengthening the muscles around the lower extremity can be quite helpful. Heat can be effective in helping to loosen up the joint and also reducing stiffness. Knee bracing can be effective in milder cases. And then we have the various forms of medication, whether it be over the counter, such as aspirin or Tylenol, and then the prescription medications, which are many. The main course would be the anti-inflammatories, which there are multiple ones. Steroid injections can be quite effective. The major problem with corticosteroid injections is that they tend to be very temporary. Most patients will find improvement after a single injection. Some patients will have improvement after multiple injections. The natural history of corticosteroids, however, is that usually after the second or third injection, there's a great drop-off in the efficacy, meaning that they don't tend to work as well as the initial injection does. Viscoelastic injections are basically hyaluronic acid, which is a major component of your normal joint fluid. They can act as a lubricant in the joint. There are various formularies of hyaluronic acid injections. Some can be given as a one-time injection. Some can be given once a week for 3 weeks. They can help reduce pain in an arthritic joint, and they can also help reduce swelling. Again, the efficacy tends to be fairly short-term in nature. Most patients can have pain relief for several months, but there's a significant increase in pain recurring after that. Now, as far as surgical options, we have both partial knee replacement and total knee arthroplasty. Partial knee replacement is indicated for the patient that has disease only in one part of their knee, usually the inside of their knee. They tend to have a bow-legged deformity. They tend to have a stable knee, meaning they don't have any ligament instability. And a partial knee replacement can be quite effective in helping patients that have isolated disease on a single compartment of the knee, whether it be the inside, which is the most common, or the outside, which is less common. Partial knee replacements can often serve as a bridge to younger patients before they require total knee arthroplasty. Total knee arthroplasty is indicated for patients that have disease in multiple compartments of the knee, both the medial compartment, the inside of the knee, the lateral compartment, as well as the patellofemoral joint, which is the kneecap. The biggest predictor of success in any joint replacement, whether it be a partial knee replacement or a total knee replacement, is reproducing the alignment of the joint so that the joint wears properly, meaning that if you were to draw a line from the center of the hip to the center of the ankle, that line should pass through the exact center of the knee joint. If it does that, then the knee is properly aligned, meaning that that joint will wear properly, will not have excessive wear, either on the inside of the knee joint or the outside of the knee joint, which can produce premature loosening due to overload of the prosthesis or potential failure of the polyethylene. And the Neoline system is an exceedingly valuable asset in order for surgeons to be able to reproduce the appropriate alignment of the bone cuts in the implant at the time of surgery. The invaluable aspect of the Neoline system is that it does not require any monitoring devices outside the surgical field. It does not change the normal pattern of how a surgeon performs a total knee arthroplasty, and there are no external devices that need to be placed into the extremity outside of the normal field of operation. The Neoline system is a GPS guided surgery that basically has a computer-driven device to allow one to determine the axis of the extremity at the time of surgery, and then to be able to set the cutting guides appropriately so that when the bone is resected, it is restoring the normal alignment of the knee, which is invaluable in determining the long-term success of the implant. The Neoline system is done as a real-time setting. There are no preoperative tests that need to be done, such as a CT scan, which are often required with other computer-guided systems. And they allow the surgeon to have real-time feel to the procedure, as opposed to other systems that require high-speed burrs and other aspects that sometimes can be very cumbersome when performing joint replacements. The two main advantages of the Neoline system are that the reproducibility of the cuts are extremely high, and compared to standard instrumentation that is used for doing total knee arthroplasty, there has been a significant improvement in the accuracy of the bone resections utilizing the Neoline system as compared to standard instrumentation. The other valuable aspect of the Neoline system is because it does not violate the intramedullary aspect, meaning the center of the femur, as is required with most standard instrumentation. There can be a significant reduction in both intraoperative and postoperative blood loss due to the fact that there is no bone tunnel created in the end of the femur or the thigh bone in order to perform the resection of the bone during the procedure itself. The other aspect of the Neoline system that is quite invaluable, it is a very quick registration in order to determine the accuracy of the bone resection. It does not add any significant time to the surgical procedure, which is a very valuable aspect of any type of computer guidance system, is we do not want to have this increase the amount of surgical time, because there is no question that increasing surgical time with the joint exposed can lead to potential unwanted complications, such as potential increased risk of infection or increased blood loss. And right now, I'd like to open it up to anyone that has any questions about what we've discussed.
Thank you, Dr. Burke. And I just want to reiterate to all of our viewers here today that if they do have any questions, unfortunately, everyone's muted, but those questions can be entered in the comment section. That's either going to be directly underneath or to the right of the video stream. So Dr. Burke, we do have a couple of questions here. The first one is from Marshall. He asked, for someone that has severe arthritis in his knee, but also has a relatively manageable pain level, what markers in bowing of the leg should he watch for in deciding whether or not to go ahead with a knee replacement surgery?
Absolutely. It is not the degree of bowing of the leg that should lead one into undergoing joint replacement surgery. It really is the patient's either satisfaction or dissatisfaction with the quality of their life. So if a patient feels that due to his arthritis and deformity, that is impeding him and leading the quality of life that he would like to lead, impeding him from being able to do things that are very enjoyable to him, whether it's walking or playing golf or other activities, then that would be the thing that would make that patient a very viable candidate to consider joint arthroplasty. Now, as part of the joint arthroplasty, the malalignment of the joint is corrected at the time of the implant. So the implant, the purpose of total knee arthroplasty is twofold. Is to eliminate the pre-existing arthritis, but also to align the knee properly.
Great, thank you. We have another question from Karen here. She wants to know if all the doctors at the Texas Orthopedic Hospital use this alignment system.
No, they do not.
Okay. One more from Tony. She says that currently she's in a cart and the pain is pretty unbearable right now. What do you recommend? What next steps do you recommend she take?
Well, the first thing I would recommend is that she be seen, ideally by an orthopedic surgeon, to evaluate her and to see the extent of the disease that is causing her pain, and then to have a thorough discussion with her about what has been done to date to help with that, whether any non-operative treatment has been done or not, and then to develop a treatment plan, ideally to help her to get over this problem and to have a joint that does not hurt.
So there's a couple questions about recovery time. Can you give an estimate on what the recovery time would look like? And then does Medicare cover this procedure at the Texas Orthopedic Hospital?
The recovery time, 99.9% of my patients have this as an overnight stay. 99% of the patients will be walking the morning of their surgery and will be able to be discharged the day after. They're able to bear weight fully. Most patients will use a walker or crutches, depending upon their preference, for a few days post-operatively. And then they can progress to either no ambulatory aids at all or potentially a cane. If they have their left knee operated on, they can certainly be driving locally in their neighborhood within 7 to 10 days. If they have their right knee operated on, I would not want them driving for about 14 days because of reaction time getting on the brake and the accelerator. The vast majority of patients are independent within the first 1 to 2 weeks after surgery, and the majority of their pain will be gone within the first 6 to 8 weeks post-operatively. And yes, Medicare does cover the Neoline system.
Great. Another one from Kathy here, and I apologize, I'm probably going to mispronounce this, but if you have lymphedema, can you have a knee replacement?
It depends on the extent of the lymphedema. The main problem with lymphedema would be the quality of the soft tissue envelope around the knee itself. And in patients that have significant lymphedema, the concern that we have as surgeons is the ability for the wound to heal. There is a significant correlation between the degree of lymphedema and poor wound healing, and having an incision not heal with a total knee arthroplasty can be a disastrous problem. So to answer that question, it would really depend on the degree of lymphedema that that patient has in their extremity, but there is no question that any lymphedema will put that patient at a higher risk stratification as far as potential risk of infection, potential risk of difficulty with wound healing, and also potential risk of developing blood clots post-operatively.
And then what about osteoporosis? How would that impact a decision whether or not to have a total knee replacement?
Osteoporosis and osteoarthritis are basically two different issues. Osteoporosis is a loss of bone density. osteoarthritis is a loss of articular cartilage. So in patients that have osteoarthritis with osteoporosis, there are certain designs of the implant that are going to be more beneficial. Normally in someone that has very osteoporotic bone, knee implants will be done that tend to have stems that will go up into the femur, the thigh bone, and into the tibia because of poor bone quality to give better support as to opposed in patients that have normal bone density. So there are certain things that we would change as far as the type of implant that would be used, but it would not affect the ability for them to undergo a total knee arthroplasty.
If someone did need a total knee replacement in both knees, do you recommend having both knees done at once?
Studies have shown that there is an increased risk of comorbidity with bilateral total knee arthroplasties, increased risk of blood loss, slightly increased risk of infection, and blood clots. It is my recommendation to my patients that unless they have a medical condition that would make it valuable for them to undergo only a single surgery, to have them done in a space procedure. And most patients can have their initial knee done and then have their opposite knee done within 4 to 5 weeks of having their initial knee done. So it's not going to be a prolonged period of time that they have to wait to have the opposite knee done. But it's my experience that patients do much better having them done as a stage procedure as opposed to bilateral total knee arthroplasties.
Okay. A question here from Lori about injections. So she says, I recently had a cortisone shot in both of her knees and it was great, but it only lasted 3 weeks. How often can I receive these shots?
Normally, I would recommend repeating a corticosteroid injection only if one can get several months of pain relief. So if an initial injection were to have given you 3 to 4 months of pain relief, then repeating that would be a very reasonable thing. If the initial injection gave that much limited relief, then I would not recommend considering a second corticosteroid injection, but perhaps would look at viscoelastic injections such as some type of hyaluronic acid or something like that. There's no limit to the number of injections that can be done, but being that said, I would only recommend doing them in a series if one is able to get at least 3 to 4 months of pain relief per injection.
Let's see here. Betty asked if you recommend physical therapy after the surgery.
Absolutely. Low impact exercise especially. One of the very best things patients can do after total knee arthroplasty is a stationary bike, whether it's an upright bike or a recumbent bike. The whole purpose of that is to allow the knee to move, to bend. Other activities that are very good are walking on a flat treadmill, an elliptical walker, being in a swimming pool 3 weeks after surgery. Those things are quite valuable in helping the patient to recover.
Mike had a question about partial knee replacement surgery and trying to kind of figure out if he's an ideal candidate for it. He's had a couple ACL replacement surgeries, and he's been scoped a couple of times. Right now, it's a little bit difficult for him to get off the floor. I know it's difficult in this medium to kind of evaluate that, but what do you recommend in terms of partial knee replacements?
In order to determine whether or not he would be a candidate for partial knee replacement, he would have to have disease or arthritis, normally in a single compartment of the knee, usually the inside. His knee should be stable. That means that he doesn't have any instability due to an ACL insufficiency. And ideally, the kneecap or the patellofemoral joint should not have significant arthritis, although there is some discussion about patients doing well even in settings of having a fair amount of arthritis in their patellofemoral joint. So those are the things that would need to be looked for to determine whether or not he would be a good candidate for partial knee replacement. Would be the location of the arthritis, the degree of deformity, how much is his knee bowed, and also whether or not he has a stable knee from a ligamentous standpoint.
Can you comment on how higher weights and BMI can play a factor in whether or not someone might be a good candidate for this procedure?
The higher weight BMI patients, there is a potential increase of loosening of the prosthesis because of the joint reaction force due to the patient's weight. Most joint replacement surgeons like to see a BMI, a base metabolic index, of under 35, ideally. But the other aspect of it is where does the patient carry their weight? Is the weight mainly in the abdominal area with not significant fatty tissue around the knee? Or is there significant fatty tissue around the knee itself? In patients that have a significant amount of adipose or fatty tissue around the knee, those patients can be at a much higher risk of developing complications with wound healing, infection, and also potential blood clot issues. So it's not necessarily the number of the BMI per se, it's also a combination of where is the location of the adipose tissue as well. But in general, patients that have a higher BMI above 35 or over tend to have more complications as opposed to patients with a BMI under 35.
Okay. Let's see here. Generally, how busy are you, and do you do the procedures yourself? That might be what's the expected wait time question.
My office is there to take care of the patient. I am not going to promise a patient that I can do this the very next day, but I will absolutely make sure that we do it as expeditiously as possible. There is no reason that I have patients wait any significant time, as long as there's no need for any type of significant preoperative medical clearance, such as potential cardiac clearances or things like that, that sometimes can delay the ability to do their surgery.
And then PRP injections.
PRP.
Yeah, exactly. Can you comment on PRP injections?
Platelet-rich plasma, or PRP, has been shown to have some limited efficacy in osteoarthritic joints. There really have been no good to date blinded studies to show that PRP has a significant improvement over either corticosteroids or viscoelastic injections. The main difficulty of PRP is it does require a patient's blood to be drawn, which may or may not be a problem for certain patients. It has shown to be efficacious in certain patients, but again, there have been no good double-blind studies yet that show it to be superior over corticosteroid injections or viscoelastic injections.
Very good. It looks like that's all the questions we have at this point. So what I'll do for all of our attendees here is in the comments section, I can list different ways for you to contact Dr. Burke in his office. You can either call him, email him, or visit his website. I want to take the time one more time to thank all of our attendees and Dr. Burke for hosting our knee pain seminar. And again, Dr. Burke, thank you very much for your time as well.
Thank you all. I appreciate everyone attending.